This is Dr. Raghav here with your OncoCare Advisor. Today I want to talk about a couple of case scenarios, but someone whom I saw about a week ago. This is both regarding breast cancer and it was HER2 positive breast cancer. First, let me talk about the first case. So I had someone who is in her 40s, diagnosed with early stage breast cancer. Early stage meaning that it was stage 1 or 2 or 3, generally 1 or 2, and she was diagnosed with stage 2 breast cancer. The tumor was bigger, but lymph nodes were negative. So anytime there's a new diagnosis of breast cancer, we ask for ER, PR, and HER2. So these are signals that help us to identify what is the best way to approach the case. So in her case, the tumor was ER and PR negative. That means that there are no estrogen or progesterone signals, meaning that it doesn't respond so well to endocrine therapy or hormonal therapy. But HER2 was positive, indicating that anytime the tumor is greater than 1 centimeter, and we know that we need surgery, we typically try to consider giving chemotherapy with targeting the HER2 therapy before surgery. It's called neoadjuvant. Neo means before surgery. So she received treatment that comprised of chemotherapy with trastuzumab or Herceptin and pertuzumab, which is Perjeta. Again, they are what we call dual blockers of the HER2. So what happened? Early stage breast cancer, stage 2, ER, PR negative, HER2 positive, received chemotherapy with Herceptin and pertuzumab, then underwent surgery, had complete response. With achieving complete response, meaning that complete pathologic response, CPR, meaning that when the cancer is taken out and along with the lymph nodes under the arm, the pathologist looks under the microscope and did not find any single cancer cells in there. That is called complete pathologic response. So what does that mean? Meaning that your chances of this cancer coming back in the long term is much smaller than if there was any residual disease, meaning that there was some cancer cells present after the cancer was taken out. So this person achieving complete pathologic response, the question was, what do we do next? So we still give HER2 directed therapy for to complete a total of 1 year. So that was case number 1. On the same lines, I'm going to create another case of case number 2, where similar age, similar stage, same ER, PR negative, HER2 positive, received chemotherapy with Herceptin and pertuzumab before surgery, underwent surgery. Now let's say there was some residual disease. Residual disease means when they took it out, let's say 80% of the cancer was gone, but there were still some cancer cells present there in that area, but the lymph nodes were negative. We call this residual disease, meaning that they did not achieve complete pathologic response. So in this scenario, I would not recommend Herceptin or Perjeta after the surgery, but instead we would recommend an advanced level of treatment called trastuzumab emtansine. It also goes by the name KADCYLA. What it basically means is it's an antibody drug conjugate. That means it has an antibody that attaches to the HER2 and releases the chemotherapy inside. So it's a combination drug that has shown benefit over the Herceptin based treatment after the surgery. So if I summarize this again, 2 similar patients, similar stage, stage 2, next step ER, PR negative and HER2 negative, had good physical response, surgery done. After surgery, one had complete response, one had residual disease. In patients with complete response, we give Herceptin based treatment to complete total of 12 months. In patients with residual disease, then I would recommend something called KADCYLA or trastuzumab emtansine to complete total of 12 months of treatment. I hope this was helpful. And if you have any questions, comments, or any particular cases that you want me to talk about, please let us know or DM here, and we'll be happy to address them. Thank you for your attention.